Good evening, everybody, and welcome to the Town Hall webinar on guaranteed access to healthcare. I'm Karen Christensen, the chair
Buenas
of
tardes a todos.
Tonight, we have several co-sponsors for this webinar. They're the League of Women Voters of Corvallis, NAACP of Corvallis and Albany, Casa Latinos Unidos, Healthcare for All Oregon, and their Albany chapter, the Rural Organizing Project, the League of Women Voters of Lynn County, the Lynn Benton Health Equity Alliance, and the Corvallis Sustainability Coalition. Mid-Valley thanks all of these organizations who for the first time have come together to sponsor and support this important educational event. Nearly 1 in 3 Americans goes without adequate health care and runs the risk of facing financial hardship because of healthcare costs. Now we are in the middle of a pandemic. This is a very important time for healthcare reform in our state. In 2019, the legislature created the Universal Healthcare Task Force. Members of the task force were appointed by the governor and have been directed to study and present a plan for universal healthcare to the legislature. This is now the time for all of us to learn all that we can about healthcare and influence the shape of the plan so that it meets the needs of all Oregonians. We have a really distinguished panel of speakers tonight who will help us to gain a better understanding of the task at hand. And we hope the result will be that more people will participate in this important process. I'd now like to introduce our moderator, Jason Dorsett, the incoming president of the NAACP of Lynn and Benton counties. Jason?
Thank you, Karen, and hello, everyone. And welcome to tonight's important town hall meeting. Before we officially kick this evening sessions off, I would like to invite everyone to join me in a moment of silence to reflect on what is happening today in our nation's capital as relates to our democracy being challenged. Thank you. In an effort to engage our audience members and panelists, we have designed two poll questions, and we ask that everyone participate as they are able. The poll questions will appear on the screen here in a moment, and I'm going to ask Jessica to please display those questions. Question 1. I learned about this event from League of Women Voters, NAACP, Mid-Valley Healthcare Advocates, Casa Unidos Latinos, Healthcare for All Oregon, Rural Organizing Project, Corvallis Sustainability Coalition, Lynn Benton Health Equity Alliance, or by another way. Thank you. These are our results. League of Women Voters, right. NAACP, Mid-Valley Healthcare Advocates, Healthcare for All of Oregon, Corvallis Sustainability Coalition, and other modalities. Thank you. Question 2. My greatest worries about changing our healthcare systems are, and you may check all that apply, I may lose what access to care I have now. The political opposition is too great. I don't think I can trust the government to manage a healthcare system. My job in the healthcare industry may be threatened. The system and possible solutions are too complex for me to tackle. Again, check all that apply. The results. 22% of you all have shared, I may lose what access to healthcare I now have. 80% says the political opposition is too great. 16% of you all have shared, I don't think I can trust the government to manage a healthcare system. And then 23% of you have shared, the system and possible solutions are too complex for me to tackle. Thank you all so much for engaging in this poll. This is certainly clearly based off of the results of the second question. There is a need, a dire need for us to engage in this conversation. And so I'm so happy that we are having this conversation. So as Karen said, the main reason we have asked you to attend tonight is to share information on how healthcare in Oregon is changing. As your moderator for tonight, my role is to facilitate conversations amongst our panelists, as well as help to ensure that our panelists are engaging with our virtual audience members and offering perspectives and responses to your questions. Each of our exceptionally well-qualified panelists will take 7 minutes for opening remarks and to help us understand what we can all do to create a much better healthcare system for all Oregonians. There will be ample time for questions after all of the panelists have spoken, and you will have an opportunity to submit your questions in the Q&A box that you can find along the bottom of your screen. Those questions will be sorted, themed, and then funneled to me, and then I will ask the panelists to respond to those questions. Okay? All right. Kicking us off as our first panelist is Dr. Edward Junkins. Dr. Edward Junkins serves as the Vice Chair of Oregon's Universal Healthcare Task Force. He is the Associate Dean of Assessment and Outcomes College of Medicine of the Pacific Northwest and Corvallis City Councilor. He will give us an update on the task force work and and all of the expected outcomes.
Jason?
Dr. Junkins, yes?
Can I just interrupt very quickly and have us note the Spanish language translation and have Cecilia tell people where that is?
Thank you, Cecilia.
La gente que necesita interpretación en español puede recibirla a través de otro canal. Por favor, váyase al calce de su página. En la parte de abajo hay un lugar donde dice intérprete. Si le hace hacia el centro de la pantalla, hay un circulito que dice interpretación. Si le da un clic en ese botón, usted va a poder recibir la interpretación en español a través del otro canal. Gracias.
De nada, and gracias to you. Thank you so much. And thank you, Jessica, for calling attention to that. We are so honored to have Cecilia as our translator on this evening. Thank you so much. Dr. Junkins, over to you for some opening remarks.
Good evening, everybody, and thank you, Jason, Karen, and others for getting this panel underway and this forum organized. It is my pleasure to serve on the task force, and I'd like to spend a little bit of time this evening talking about the work of the task force and the intended outcome. As stated, I am a pediatrician and an emergency physician. I live here in Corvallis. I'm also a public health officer, and I recognize the need for a change, if not a drastic change, in our healthcare delivery model. And my personal view is that community wellness will expand if we could get our healthcare system in our state exactly right. That's what we intend to do. The task force, as you heard Karen say earlier, was mandated from a bill from 2019 where the Oregon legislature enacted a bill allowing for the establishment of a task force. I was picked from a pile of applications to serve on the task force and ultimately elected as a vice chair. We meet every month as a task force, but we've also, I'll talk a little bit about the groups that are involved with the task force itself. The pandemic obviously introduced a significant delay in our timeline and procedures. So everything I'm telling you is extremely compressed, such that we will put out a plan and a process. I will put that before the Oregon legislature by May and June is our target date. The task force is a joint task force, which includes not only members of the public selected as volunteers, as I had said myself, some of whom are on tonight's panel, also members of the Oregon legislature and the legislative pro office, as well as the Oregon Health Authority staff, have all come together to put not only documents and expertise before us, but to bring actual experts before us from across the country, if not across the globe, to answer questions and to inform the task force. What are we trying to do? We are trying to present a plan of universal access to healthcare, if not a single payer plan, understanding the obstacles that other states have encountered. We've looked very closely at other states, including Vermont, Massachusetts, New York, California, Washington, Colorado. All these other states that I've mentioned, as well as others, have looked extremely closely at this kind of work. There are 22 states who enacted over 60 bills in the past several years that moved their states in one direction or another towards something like either single payer or multiple payer universal access. The goal, of course, is to make sure that everybody has the care that is required to reduce disparities across the spectrum, while preserving a variety of features that exist in a multi-payer system. As we saw in the poll, there is expected to be political opposition. On the task force, we have conversations every time we meet about what opposition looks like, and the notion that if a state plan is where it needs to be, it will serve everybody in our state and will be a logical choice. We're looking at businesses, we're looking at consumers, we're looking at rural and urban, we're looking at health disparities. The task force itself is a very intentional blend of diverse experiences, backgrounds, geographic locations from throughout the state. The task force is broken down into, at the moment, 4 technical advisory groups. Those groups allow the task force to look closely at key issues. I'd just like to run through a couple of those, and I'm watching Jason, who I know is watching my time. The first group is the technical advisory group for eligibility, benefits, and affordability. I see people in the audience who have sat and observed our technical advisory group meetings, all of which are open to the public. There's another group looking at provider participation and reimbursement, understanding the impact of across the spectrum of all providers, mental health, nursing, long-term care, the role of health plans, cost containment and financing, revenue. I'd say that out loud for my friend Dan, who's waiting to have his turn, and then governance and administration. The plan is over the next 2 months that these separate groups, there are 4 groups that are overseeing those design features, will come up with proposals and put them before the task force, which will eventually put that into a design plan and put that before the Oregon legislature by the end of session. There isn't a whole lot of time to do that, and we can't do that in a vacuum. Lots of opportunities for input from folks such as those viewing. And those opportunities include public oral testimony. My friend, Dr. Mike Huntington, just today at our meeting gave an elegant testimony from his perspective and his experience. We've had testimony from farmers, from small business owners, from individual recipients of care which has not met their needs. We also have had stacks of emails and written testimonies. all of which are summarized and put before us at the beginning of the task force meetings to remind us what that testimony looks like. We're looking for other ways to engage the public during the design process. That would mean specifically to get public involvement in these variety of design feature areas, working with technical advisory groups. Then the last group which I want to introduce is the consumer advisory group. This group was assembled from over 100 applicants from across the state and across the spectrum of insurance, either carrying insurance or not being insured. It's a representative group of people from across the state who have a stake in healthcare access. That consumer advisory group is there to reflect on and advise the task force on direction and design, ultimately to help us inform, to help us through consultation and collaboration to get the design right. What is going to happen in the end? Well, we envision, and I am anxious to hear my fellow peers reflect on what this looks like in the end. But this is something that could eventually go before the voters. This is something that's going to require, because of that opposition or because of that buy-in, a great deal of conversation. So we rely on people on the screen, as well as people who haven't even heard about Senate Bill 770 and what it could mean to them. So we're talking everybody. I've been invited, again, with Mike Huntington and others, to speak and present to the school board. We'll be speaking to executive leadership at Samaritan Health, and we speak to healthcare associates up and down the corridor. I personally have accepted invitations to go and answer questions and to speak much like I'm doing tonight. So Jason, I'm going to hand it back over to you because I have a great deal of respect for my colleagues and I'm anxious to hear what they have to say about the task force. Thank you for giving me a little bit of your time this evening.
Thank you, Dr. Junkins, for that update. We appreciate that and we appreciate your service. Our second panelist is Deborah Reddick. Deborah Reddick is a licensed registered nurse and the director of Health Policy and Government Relations for the Oregon Nurses Association. She has worked in health policy and education in addition to direct care nursing. She is also a member of Oregon's Universal Healthcare Task Force. Ms. Reddick will discuss equity in healthcare and racism as a public health crisis and provide perspective from the Oregon's Nurses Association. Over to you, Deborah.
Thank you so much, Jason, and thank you, Ed, for that overview. As was mentioned, I represent Oregon's Nurses Association. Currently, that means 15,000 nurses all across the state. I also represent the Nurse Practitioners of Oregon, and I have to honestly say that our nurses' alignment with universal healthcare predates me. I've only been in the state for just under 3 years, and we were partners in this effort and with Healthcare for All Oregon long before I got here. And so I am really proud to take up the mantle and to continue the effort around making sure that everybody has insurance, and insurance not just simply that provides access, but that's also responsive to their unique needs. I first want to talk about, just to put a pin in what Ed Jenkins just said about disparities and just give a definition. Health disparities are preventable differences. Okay, these are things that are man-made in terms of the differences and distinctions. And that's around the burden of disease. It's around ability to obtain your optimal health status, and just how you intersect with the system. That's what health disparities are. It says that, if I show up looking the way I do as an African-American woman who is middle-aged, that my outcomes, despite the fact that I have relative privilege because of my education and experience, they are going to be different than someone who is, for example, white, who has the same amount of education and experience and is of the same age, simply because I look the way I look and I present this way in the world. And so we just have to understand that as being one of the foundational pieces to why it is so very important for all of us to try to support universal healthcare. And I think that the project that was implemented as a result of the task force and the Bill 770 is because we need to think about the system that we're creating. I think it's very important that as we start to think about how we would go about covering everyone, that we do consider things like language access, that we think about things when we talk about access in terms of how scheduling goes. I think that it's really important if we're talking about access to make sure, again, if we're talking about provider groups, that those providers are able to provide the kinds of services in the ways that people need them. Access is more than simply just having an insurance card and a place to go. It's making sure that you don't have the apprehension that you're going to be discriminated against when you get there. It means that when you get there, if you speak a different language, that there are interpreters, that there are materials that you can understand. It means that people are able to understand your cultural needs and, you know, whether or not hot and cold has some impact on the way you perceive the system and your care. All of those things are critically important for the kind of care that everybody needs in order for them to feel welcome and for them to take up the recommendations that the providers all across the state who will be a part of this system want to offer. So when we talk about that, I think that we can't get around the fact that when we talk about disparities, I think one of the things we all know is that COVID has certainly shone a light on some things that have been in place for a really long time. And some of that is simply the fact that we have treated people based on, you know, their language, their ethnicity, their race quite differently as they access the system. We do a pretty good job here in the state on covering every child, which we should be really proud about. But we need to try to transition that and what that means for adults. We know that our adults are, again, our economic engine of the state, that if we are not healthy, that we can't go on to make our budget and the things that we need to do for all of our citizens actually meaningful. We can't actualize them. And so having this healthcare and this infrastructure in place is going to make a difference, but only if it can make a difference for everybody. The other piece of this is about equity. The system has to be equitable, and equitable is
Jason,
not
it looks like Cecilia needs a pause.
Certainly.
Sorry to interrupt you.
No worries.
It looks like
Can you
she's
hear
asking
me?
to go back a little bit.
Deborah, I apologize. You need to go back about 5 sentences. That's how far I got behind. I apologize.
The point I was making is that the system really does need to be responsive. Because we have insured all of our children, it's really important that we also now make sure that the parents and the family members and the mentors and the support system for those children are equally healthy. If we don't have healthy adults, then all of the efforts that we're doing for the children will, again, not get us to where we need to be. When we talk about healthy adults, the implications for that are economic, they're moral, okay? We need the infrastructure of people who are going to drive all of the policies, all the decisions, all the supports that we need for future generations, and that is really important. And so when we talk about equity, we've got to talk about racism. We know that COVID-19 has shown a light on racism in a real way. It's always been there since the implementation of our country, and we've got to acknowledge that, but we've got to move beyond that. We can't be responsible for the decisions of our predecessors, but we are responsible for the actions that are going on now and our steps to sort of remedy some of these problems going forward. I genuinely believe that. And so we've got to take that factor of what you look like, how you show up in the world out of healthcare. I think that we truly as an organization support this because we are the workforce. We see more patients than nearly every other profession, and we see the stories. We have the burden of having to deal with people who can't afford healthcare or who can't understand the system or who are afraid to come into the system because, quite frankly, they've not been cared for in a way that they thought was respectful or responsive. And that really is a burden for our nurses, and they see it. And that's why we've gotten into this discussion. That's why We applied to have a seat at the table to try to come up with some of these solutions because we feel so strongly as a profession that if not us, then who? And we will continue to stay engaged in the conversation. We hope that everyone here will, if you have questions, reach out to get more information, and that you'll at least commit to telling a couple of other people about this initiative because it truly can be a game changer. Oregon for so long really has been a beacon of healthcare and innovation for the entire country. And it's my hope that we can continue that by getting a really robust health system that will address the needs of every person who is within our borders. Thank you.
Thank you, Deborah. Thank you for challenging us to look at healthcare from a lens of equity. And certainly, as you mentioned, we cannot talk about equity without talking about racism as a public health crisis. So thank you for your expertise and thank you for your service. Our next panelist is Olivia Quiros. Olivia is the Executive Director of the Oregon Latino Health Coalition and a health policy specialist with expertise in chronic disease prevention, food policy, and child and family health. She will discuss healthcare equity, healthcare for farm workers, and the interactions between the federal and state governments. Over to you, Olivia.
Hello, thank you, Jason, for the introduction and to all the organizers here. Good evening, buenas tardes. Again, my name is Olivia Quiros. I'm the Executive Director for the Oregon Latino Health Coalition. We're a statewide coalition based out of Portland. We started off as a volunteer-led organization back in 2004. And up till 2012, we hired our first executive director. And our mission is to advance and eliminate health disparities for all Latinos, Latinx, Oregonians, in particular looking at access for our immigrant, refugee, undocumented communities. And the Oregon Latino Health Coalition has pioneered statewide health policy and advocacy initiatives and expansion to the Oregon Health Plan. In 2018, we pioneered with a coalition over more than 40 stakeholders across the state that included community leaders, coalitions, healthcare advocates, state representatives, CCOs that came together to ensure that all children across the state of Oregon, regardless of their immigration status, would have access to healthcare. That campaign took over 5 years of work. So if we, when we talk about the political opposition, our organization faced a lot of that racism, discriminatory environment, and that it's actually rooted in Oregon's history too. So it didn't come from nowhere. So it was a 5-year campaign that led to the expansion of the Oregon Health Plan. The campaign was called Cover All Kids. Oregon is one out of 7 states across the nation that has a similar plan. And what this means is that children under the age of 19 can now enroll into the Oregon Health Plan, which is a state-funded program. Our organization this past session in 2019 also led efforts to secure funding for the ongoing implementation. So we were talking about a fairly young and new population that was introduced to a very complex healthcare system. So issues around language, issues around just filling out your 30-page OHP application is very, very complex for the parents of these young children that are non-English speakers, are new to this country, and also some longstanding residents that have developed and have established deep roots in our state. Our organization led the outreach and enrollment element of the Cover All Kids plan, which means that we deploy a community health worker model to outreach to these communities, to assist them in their application process, and to do a big, large portion assisted navigation support, which is connecting them to the healthcare provider and answer any questions in terms of their follow-up care, and connecting them to the CCO structure, which is another arm that's very complex to navigate, and that many families are not aware what type of eligible services and programs they can receive. And so this is part about not just expansion of healthcare, because that doesn't ultimately mean that we're going to move the dial in health equity and health outcomes. It means a larger comprehensive outlook. It means that right now, as our communities of color, the Latino community specifically, entered the pandemic, we came into this pandemic with historical inequities and disparities. So it's beyond access to healthcare. It's about economic wages. It's about educational disparities. It's about the current workforce of our healthcare providers, which we have a great shortage of. We don't have the bilingual, bicultural providers that look like us. And therefore, in this system, it can translate to medical bias. It can translate to the lack of quality care that many of our communities need. And so in terms of where the health inequities and COVID-19 has exacerbated our disparities, is that right now the Latino community in the state of Oregon are 12% of the population, close to 13%, yet we represent 39% of the positive COVID cases. And we continue to have large outbreaks across the state of Oregon, in particular to workplaces, and in particular with the farm worker community. During the summer, we saw one of the largest outbreaks in food processing plants across the state. These go across in Pendleton all the way down to Southern and the Oregon coast. And we saw more than 40 to 60 outbreaks, and then trickled even to higher numbers that resulted to families that don't have the privilege or the opportunity to work from home. All of us here are in a space where we can log in and we can do these virtual conversations. But for many of our farm worker, essential workers, that now is a term that's been coined in the pandemic, they don't have that opportunity. They're there every day. They work 8 to 10 hour shifts. They work in crowded spaces. Our farm worker community travel from different parts of the country. Oregon is an agricultural state. They provide the grapes, the organic blueberries that we also love, and that, you know, that we eat. And yet, when from a stimulus kind of standpoint in the federal administration, we saw that the first round of CARES money that came to Oregon and across the nation excluded the farm worker community, excluded the undocumented community from receiving stimulus checks. And so in Oregon, I think that we had great leadership with our governor and other state representatives and advocacy organizations, sister organizations like PECUN, like CAUSA, our immigrant advocate organizations that quickly came together to ensure that care funding in the state of Oregon would be allocated for the farm worker community, which turned into the Oregon Worker Relief Fund that provided that financial relief so that families that came close or were infected by COVID could safely quarantine and not worried about the economic impact, not worried about not being able to pay the rent, not being able to pay their internet, stay safely home, quarantine, and have the means to provide for their families. This is all connected to the health outcomes of our communities and the disparities. And as many advocates across the nation in terms of the interactions that we have within the federal and state government, this next round of stimulus funding that was just approved by the federal government, it lasted till I think the very last minute when we really were, watching that and tracking and seeing how the distribution of those funds and who would also be prioritized and who would be included in that package. Luckily, many other communities of color were included, such as some of our Asian Pacific Islander communities. It will provide some stimulus relief funds for mixed status families. And so we're very excited about that, because that helps many families in the financial situation that they're facing. And I think just to kind of close up and move in terms of what we can do and what our organization is doing in terms of call to action, and continue to raise the alarm, not just in terms of the COVID cases, because they're still high, they're still impacting our community. And many of our communities are dying from this virus and this disease. We're moving into vaccination. And so we do, have a call to action that to ensure that vaccination is available to prior populations in our communities of color. We're bearing the brunt of this economic burden. The Latino community is still at 11.5% who are uninsured here in the state of Oregon. That's compared to 5.4% of our white counterparts. And so we still have a pretty big disparity rate. We don't have adults that who are undocumented immigrant. They don't have access to the Oregon Health Plan. So that's a big gap and a big access that we do call health advocates here in those developing plans, that is inclusive and that ensures that it's driven by the dignity of, healthcare is a right for all, and that regardless of where you come from, regardless of your immigration status, as my colleague Deborah was mentioning, this is a large portion of our community that does not have access to a medical provider, cannot call if they're feeling sick, if they get contacted with COVID. There's long-term health impacts that we are still learning about. We're hearing directly from our communities that have developed ongoing migraines, have developed memory loss, which is new. And I think, the research and as this pandemic is very novel, we want to make sure that they're taken care of so that they can go back to work. They're the engine at the heart of our economy as well. And we want to make sure that all of these policies include our communities so that they also have the opportunity to live a healthy life. So,
Wow.
yeah.
Wow. Thank you so much, Olivia. And thank you for calling attention to the historic racist past of this very state. It is very important that we contextualize not only this conversation, but that we contextualize the history of Oregon. And thank you for serving as a champion for your community as relates to healthcare equity, for specifically for farm workers and for the Latinx community. So thank you so much. Our next panelist is Mr. Marty Wildy. Marty Wildy has represented District 11 in the Oregon House of Representatives, which includes parts of Lane and Lynn counties since 2018. He is also a member of Oregon's Universal Healthcare Task Force and serves, and Representative Wildy will discuss universal healthcare across party lines. This is a very, very, very great conversation. Universal healthcare across party lines and drug and hospital cost controls. Over to you, Marty.
Well, thanks. Just to introduce myself a little, I'm a lawyer and a legislator, and I've been a hospital counsel and have degrees in health law and administration. I like to say I've done all the least popular jobs in healthcare. But most important for this conversation, I grew up on Medicaid. And so, my task today a little bit is to talk about how we might pay for this and how to work cross party lines to get there. I like to sort of zoom out when I'm addressing a problem and sort of get a sense of how big it is. So, what's the size of the problem we're trying to solve? Well, we spend about $31 billion a year annually on healthcare in Oregon. And that's a big number. So how can we reduce it to something more manageable? So I like to start by saying, look, the federal government might give us some flexibility with the money that they collect, but they're probably not going to change the way they collect it. So I've been taking Medicaid and Medicare, the VA, and other federal healthcare systems is more or less a given that they're going to continue the way they collect those. So that leaves us with, how much of that 30 billion or so is paid for by private insurance, because that's the piece we're really trying to get at. And it's about 10 billion. It's still a big number, but one we can put into context. And I would say the political context here is that every major revenue reform goes to the voters. in Oregon. So it has to raise enough money and it has to be popular enough to survive a vote of the people. So just to give you a little perspective on the taxes we already collect. Yeah, we collect about $6.4 billion a year in property taxes. So if we were going to use that as our funding mechanism, we'd have to increase property taxes about 160%. And people probably be pretty upset about that. If we did a sales tax to get to 10 billion, we'd need about a 7.5% sales tax. People aren't real excited about sales taxes in Oregon to begin with. And a typical sales tax split in terms of who pays it in another state is about 1/3 paid by businesses and 2/3 is paid by consumers. So, you know, we'd be shifting a lot of expense off of business books as well. So I assume people aren't too excited about that either. Business income tax. Well, Oregon collects about $1.4 billion in business income taxes biannually, or about 7% of what we need. So can't leverage that. The corporate activities tax we passed nets about $1 billion a year at a rate of 0.57%. Now we'd have to raise that up to about 6%. That would be possible, but probably not really a first choice as a funding mechanism. So you know, personal income tax is the other one. We bring about $9 billion a year in revenue through personal income taxes. So we'd be more than doubling it and effectively shifting all the burden off of businesses. So people probably wouldn't be real excited about that. So now we're down to it. We already pay for Medicare and Medicaid with payroll taxes. So why not healthcare? Businesses are already paying premiums for healthcare. So restructuring the expense isn't a huge deal. It becomes a deductible expense on their taxes, like healthcare. And the question is, you know, how high would you have to set it? Well, the answer is about 10%. Payroll in Oregon is about 100 billion, so payroll tax would have to be about 10% to raise 100 billion. You know, realistically, I'd expect you'd have to have some kind of employer-employee split, probably around 80-20 or 8% and 2%. So that's, I'm not advocating any of that. I just like to go through that because it gives people some idea of the ways we might collect money to pay for it and what that would mean for individuals. Now, the other question, I would say payroll taxes are not the most toxic form of tax in politics. For instance, Eugene recently passed a payroll tax to fund more police that was actually ended up being supported by the Chamber of Commerce. So it's not impossible. Now, the other question I've been asked to answer is, you know, how to address hospital and drug costs. And so Paul Getty was a oil industrialist, and he said, if you owe the bank $100, that's your problem. But if you owe the bank 100 million, that's the bank's problem. And so what I would say is, when you have a single payer system, that really gives you an advantage in negotiating. I mean, normally we'd call that a monopoly and it would be illegal, but because it's the government, we're allowed to do monopolies. So for each of hospital costs and drug pricing, I'm going to talk about one thing we can do to reduce costs up front, and then talk about how we reduce, you know, how we negotiate better. First, for hospital costs, the one thing everybody agrees on is prevention, keeping people out of the hospital. The way to do that is through population and public health and primary care. Hospitals are indisputably the most expensive place to receive care. If we can have people go to their doctor's offices or urgent care for non-emergency conditions, we can save a lot of money. And if we can reduce the cost of chronic disease, we reduce the cost burden in hospitals as well. Second, a single payer system has the power to set global budgets for hospitals. If you're the only one, if you're the only insurer, then you decide what you're going to pay. You know, ideally, you exercise that benevolently, encouraging positive practices. But the hard truth is, when you're the only buyer in town, you set the price. Drug pricing is sort of similar. First, a single payer system has a greater ability to set formulary rules based on effectiveness. It's another important cost savings. You know, we're one of the few countries in the world that allows prescription drug advertising, and we certainly see the cost of it. I'll just put it that way. People often want drugs that either are not appropriate for their condition or are not the most effective drug for it, and often cost more. I guess I would say the other piece is again, negotiating power. as a single payer system, again, you're the only buyer in the state to a large degree. And that in the absence of a more substantial federal change on drug pricing, that is the most effective way to do it, is sort of banding together and negotiating for those as well. Frankly, that's why the VA, I believe, paid about, when the new Hep C drugs came out, I think they paid between 20 and 40% of what private payers were paying for the drugs, is because they had the scale to negotiate it as well. So that's all I have. Thanks for your time, and I look forward to answering your questions.
Thank you, Representative Wildy. We appreciate your perspective and we appreciate your boldness as relates to striking a deal across party lines. Thank you so much. Let's turn it over. And again, we're going to try to make up some time here. Let's turn it over to Representative Rayfield.
Thank you very much, Jason. Thank you for all having me. I just always say this because normally these are in person and I really miss seeing everyone. And so I shamelessly go down the attendee list to spot people I know, and somehow that makes me feel better. So please know that I see you, whether it's, Joanna Cliff Tro or Janet Wolfesh. Hello. It's good to kind of see you. For those of you that don't know me, my name is Dan Rayfield. I'm a state representative from the Corvallis area. My background in the legislature currently is I serve as the co-chair of the Joint Committee on Ways and Means, basically the committee that develops budgets for our agencies. We look at policy options when we're deciding, with our limited resources, when we have budget cuts that we have to make. Those are the things that we have to decide on. I mean, frankly, it's behind the scenes, but it's really meaningful work for, frankly, everyday lives for Oregonians. What I wanted to do first off was just say that universal health care is a movement. And my son is now coming and is barking next to me. That's really so inopportune. We've been going for so long. Hey, Adam, can you close the door, please? Thanks. There we have it. See, this is no, seriously, close the door. Anyway, he didn't close the door. We're going to keep moving. Hey, buddy. Oh, so sorry. This is so much fun. This is the pandemic, the heart of the pandemic. Thank you, Adam. I really appreciate it.
This is real life, Representative. So take your
Holy
time.
moly. And session starts Monday, and this is going to be going on. But the real kudos should go to my wife, frankly, who allows me to do this work. So back to kind of where we are is I really believe that universal healthcare, ensuring that everyone has healthcare, is a movement that has been going on for a long time. It's a movement, in my personal opinion, and being a part of it, that is gaining momentum and speed as we continue, at least at my short time in the legislature, my short time of being passionately interested in ensuring that everyone has healthcare. I also want to note that I think, as you noted today from Deborah or Olivia, there are other significant issues, equity issues, that you just don't address by passing, healthcare for all, right? I mean, we need to know that we can work on all of these things on parallel paths. And so I just think that's really important that we think about that. My role today was supposed to talk about a little bit about the big picture and the environment that we're operating in today. What does that mean for healthcare in the upcoming session? The first thing to note is normally in a session, we have these really grand ideas that we come in, right? And legislators come in excited about that. And we have unlimited amounts of bills that we can draft. And we have these big policy agendas. The last year has complicated what I would call a normal legislative session, where we are now adding multiple crises into, frankly, into our sphere. And then I would also add that we are, what I would say is, for some ways, frankly, discovering pre-existing crises that have been existing for the history of our country. And those are being raised, basically elevated to a level where we're finally starting to make some meaningful change, but there's a whole hell of a lot more that needs to be done. You layer that onto an existing typical agenda, and it becomes very big. It becomes more challenging in a socially distanced environment to tackle some of these things. You add on the layer of, we're going to approach a legislative session where we are going to be short roughly probably about $1.3 to $1.5 billion. We have to continually address the current pandemic, right? When we talk about healthcare disparities, right? And I think Deborah really talked about this. Olivia really talked about this. How this really just put a magnifying glass on the inequities, all across healthcare. Those are massive responsibilities that we're going to have as a legislature to address in a very difficult session with less resources at hand. We have an immense responsibility, and I think there is the set of values in the Oregon legislature that we have to preserve the core services that we're offering here in Oregon. That has to take the utmost precedence. And you think about, I think Representative Wildy talked about this, the Oregon Health Plan right now is roughly, when you think about total funds, federal and state funds, roughly about $18 billion that we spend on that. That is a considerable amount of, it's about 20% of the state's budget right now. No, seriously, let me finish, please. Code word, Adam. Oh my gosh, he's right now he's playing a dog and he literally bit my notes and ran off with them. So the dog ate your homework, I guess, is the classic thing that is said. So I'm just gonna continue on from memory and see how well this does. So what ends up happening is we have this massive state budget that we're gonna have to work on in terms of, he's back. Thank you. No. So I need you to go. The code word, remember, blab. Thank you. We have a code word that I say when he's overstayed his welcome, and that code word is blab. All right. So I just want to add that context of, as we're looking there, I don't believe that a pandemic or a wildfire crisis is an excuse for the legislature not to make progress. It never should be that way, and we shouldn't settle for that status quo. And I believe that Oregon is set up very fortunately with historic reserves. I think we have a new administration, and I might let my colors shine. Hell yes, Georgia, yesterday, with the new administration coming in and having the support that I think will allow us the flexibility to really make meaningful progress on some of these things. When you think about the changes that maybe don't excite folks initially, where you're saying, hey, social determinants of health. Typically, that hasn't been an incentivized reimbursement in healthcare, right? We have the opportunity in Oregon and in this country to set an example where we can start coming back and saying, yes, social determinants of health is health. Right. And we can start making these changes. There's a movement to look at amending our waiver to get reimbursement for these things. So I think there's in a very challenging day, and Jason, we talked about you at the very beginning, right? A very challenging day. There is an immense amount of opportunity and optimism, at least that I see moving forward in such a challenging year to move forward. Some of the other things that I think are just interesting to note is 1 in 4 Oregonians are on the Oregon Health Plan here in Oregon. Keep that in mind, like as you walk through your counties. Rural Oregon experiences much. I'm getting better at this. Rural Oregon is experiencing you'll see much higher percentages of communities impacted with the Oregon healthcare or on the Oregon Health Plan. Interestingly, during the pandemic, caseloads have grown by about 15.6% here in Oregon. That's dramatic. Part of the reasons for that, we actually got a new puppy, and apparently we've got a second puppy now. Mr. Junkins also got a puppy as well. One of the things that allowed us to have, it's 168,000 new members on the Oregon Health Plan this last year. One of the things that allowed us to do that was our increased match rate from the federal government that allowed us to be able to pay for that and some of the other essential services. This is really him saying that he wants attention, and I want to be respectful for that. And I'm love to have him in my life. So I feel very fortunate.
And Representative Rayfield, I
Yes.
actually on that note, because I see we have quite a few questions that I'm going to toss your way. And so I'm going to open this up now. And if it's okay with you, we're going to just pause you for a moment there.
I welcome that.
Thank you. And let's get some of our questions from our panelists. From our guests. Again, panelists, thank you all so much here. And thank you to Jessica and Camille and others behind the scenes that are funneling these questions to me. So let's kind of go back, if you will. We have a question in here that is, I'm going to ask Dr. Junkins, Ed, to kick us off. But there's a question in here about how can I give input to the task force? So how can residents of Oregon give input to the work of the task force, Ed?
Yeah, thank you for asking that question, Jason, and for the listeners out there. The task force is working hard to solve as many problems regarding public input as we can. We just had a 35-minute discussion, which I led, about public engagement. The following ways are valid and should be accessible, and that is to visit the task force website and just view where all the meetings are, look at the agendas, look at what has been recorded in the past, but also sign up to speak, sign up to get involved. That's oral public testimony. There are ways to send in written testimony. We've heard personal stories, life stories. Send in written testimony. If you are paying attention to the technical advisory groups, we have 4 groups plus the Consumer Advisory Committee. All of those groups have options and have the availability of public testimony and input. So I encourage you to look at the schedule of the 4 different technical advisory groups and the Consumer Advisory Group for input. We are looking at ways of having more of us go out and do these kinds of forums. I talked today about this very forum during our meeting. In fact, we posted the link for this forum in today's meeting chat stream. Individual members of the task force have been invited to chapters of the HCAO and other groups. So we will come in and talk to your group as well. And we're looking to send out specific invitations to see if we can get to the perspectives of those who are underserved and underrepresented, as well as who've had poor outcomes, as my colleague Deborah and Olivia have pointed out. So a lot of different ways to get involved. With the pandemic, the opportunities are actually, I think, more accessible because we are thinking of ways to do virtual town halls, virtual outreach, a virtual roadshow when we're looking at the buy-in phase. But we encourage you to get involved now during the design phase. Thank you, Jason.
Son, you were-
Thank you. I was muted. Thank you so much. Maybe let's start with Deborah, and then perhaps maybe Olivia, you want to contribute to this question or respond to this question. How would people with disabilities be covered?
Sure. So, one of the things that we're doing as a part of the task force is, actually thinking about what kinds of services are included. And there are 2 disabilities rights voices that are at the tag in which I'm participating, which is on provider reimbursement, to make sure that those things are addressed and considered. And so we're going to try to make it as equitable as possible. The things that would be, available to able-bodied, fully-bodied patients will be, things that we consider to make sure that you're living as fully a life as any of the rest of us, to the fullness of your capacities. So that's something we're taking very seriously. That's something that we have already started to consider about how we do it. We're not anywhere near where we need to be. As Ed pointed out early on, we got a late start, but it is in nearly every conversation. There is a conversation on how it would look for everybody across the spectrum of ability and conditions.
Yeah, and I'd like to add to that in some of the comments that Dr. Ed mentioned in terms of meaningful community engagement in a virtual space, which does pose a barrier for communities that don't have the technology to engage in this space. And so how do we do a targeted outreach to the disability community, to communities of color, to the Spanish-speaking community, non-English speaking communities, so that they can engage in these opportunities that is shaping policy, shaping the development of the next wave of access for healthcare for all. So I do encourage all my peers and people on the call to do direct investments in regards to your outreach in communications. I think that by having an interpreter in this town hall is an example of how to reduce the virtual barriers that is adding to our communities. We're entering a session that Representative Rayfield mentioned. And so how can your constituents and Representative Marty, can you reach to communities in this virtual space, and how can we make investments on the technology gap that exists in our communities of color?
Thank you. Thank you so much. Okay, let's hear from some of our representatives that are on the call today. Let's start with Representative Wildy. We have a question here from an audience member that is asking, why should I pay for someone who has no job and has not cared to get health insurance? We'll start with you, Marty, and then we'll swing it over to Dan. Why should I care?
Well, I guess the short answer is you're already paying for health insurance after the ACA in 2009, which came into effect in 2014. I guess on a more sympathetic note, I would say, when I first became a long-term care ombudsman, I volunteered in long-term care, and there was a place called New Seasons that it really started up after Obamacare came into effect, and these single folks without children first got covered, and they were almost all very mentally ill people who had been living on the street. And because we expanded Medicaid, they were able to, have 3 hots and a cot, medical care, and a decent standard of living. Now, it was in no way a luxurious lifestyle, I would say. So your funds were not being spent on anything beyond, those fairly basic needs, but it was a very humane way of doing things. And actually, frankly, when you look at healthcare, Medicaid is our most affordable program as well. So there was another question about reaching out to minorities in the community. I do really try to make an effort. I would say, candidly, I have one of the whitest districts in the state. It's 94% white. I do reach out when to organizations that represent people in my district. That's one of the primary things I do. I also, I have the university, so I have a lot of non-traditional folks, so I do reach out that way as well. So the bigger issue for me, honestly, is folks living in poverty and getting people access to the programs that we do set up. And so when they defunded navigators and things like that, that's a real problem, because these are not folks who necessarily are going to know how to do that. So I work with the county and try to coordinate those and outreach to those communities as well, so that people know that they can literally just walk into the community health center and there'll be someone there who speaks their language, or connect them with someone who speaks their language who can get them enrolled right away.
Thank you, Representative Wildy. Over to you, Representative Rayfield again. Why should someone who has no job pay? But I'm also going to tack another question onto that for you, Representative Rayfield. We have a question here that is asking about, could you talk a little bit more about the Hope Amendment to the Constitution? That's a great question.
Absolutely. And so we'll start off with the one that Representative Wildy tackled. And I smirked a little bit when he said, hey, you're already paying for it. But there are folks that like practical sense matters for them. And it was, prior to the Affordable Care Act, it was even more pronounced, where someone goes and do emergent care and they don't have the ability to afford it. And healthcare is provided to these individuals. And it's not like they're not getting health care, but that bill would not be paid. And they are compensated, where it rises the healthcare costs for everyone else, in the entire system, and things like that. So you may not think you are, but underneath there are mechanisms. Frankly, it happens within healthcare plans where we've seen the state healthcare plan have be forced to pay higher reimbursement rates, with certain entities, whether it was hospitals or others, where you had private insurance companies that were paying lower insurance rates. And so public employees, your tax dollars, were subsidizing private plans and reimbursements. And so those dynamics are real in the insurance space. So I say that from a mathematical perspective. For me personally, I think we all have to sit back and look at what type of a state, what type of a country do we want to live in. I personally would like to live in a state where healthcare is a human right and that everyone has access to healthcare. That's just it's a personal value, it's a belief, and I stand by that. I also recognize that there are some that don't agree with me about that. My hope is through movements like this, we start to get people to share that value, and appreciate that. And so it's, again, very thankful for being here. On the next question, the Hope Amendment, for those that are not familiar with the Hope Amendment, this was going to be a constitutional amendment that we would have passed. The late Mitch Greenlick, this is his big passion, which would have enshrined into our Constitution healthcare as a human right. Unfortunately, it was something that had passed out of the House, and it died over in the Senate. And it was very unfortunate. It was something that was very passionate, frankly, for a lot of us. But really, there was an additional personal meaning for Mitch Greenlick, Representative Greenlick, as that was one of his last wishes to see that happen. And I think there are many of us in the legislature that are still very committed to that. There is a political side to this. I think it was important to note, there are some that would support the ambition behind the Hope Amendment, okay, that really believe that it should be a human right and it should be in the Constitution, but are fearful that if it gets turned down at the ballot, what does that do for the movement, right? When we haven't had the opportunity as a state to fully engage in this conversation. You think about marriage equality. There was a long education campaign before that preceded, the big the moment where we finally got to where we were headed, right? And there are some that are concerned that we haven't had that education component and that something failing at the ballot would be catastrophic for the movement. So know that there are different sides and people who support it that may not necessarily support the amendment. So, and there are others like myself that believe the time is now.
Thank you. And just a follow-up question to that, just a simple yes or no from our representatives, maybe. Will chiropractors be covered in this sort of state-based health care? Do you know? Chiropractors.
I leave it to the folks who are actually designing the plan. My job just to figure out how to pay for it.
Okay, maybe.
I believe they should be.
Okay.
There is chiropractic equity.
Yeah, we are considering the full breadth, not simply chiropractors, but everything, including community health workers. I mean, the entire range of services that our populations need, we're trying to meet their needs so that they can achieve health, and there will be fewer costs to the system in the long run. So we're thinking about everything soup to nuts.
Oh, wow. Thank you.
And I would add, Jason, I would encourage people to actually pull the bill and look and see what it exactly says. I'm looking for the word chiropractor, but we have not actively excluded anybody. So I believe that, as Deborah said, it is an inclusive effort.
Thank you all so much. Okay, next question here is we have about 15 minutes left. So if your responses could be could be brief, I would appreciate it. How will a single payer system be best administered at the regional level as well as the state level? And I would like for maybe Ed to kick us off with some thoughts and then invite whomever else to respond. So at the regional level and the state level, how will a single payer system be best administered from your perspective?
Yeah, so I'm going to answer very quickly and say we have a specific technical advisory group with members of the task force looking at governance specifically to answer questions like that. And I would defer to the expertise brought in to inform that group to answer that question. It's an excellent question that has been brought up many times. Maybe one of the other task force members remember it differently than I.
Okay.
No, I
Well-
would say that is accurate. What I can honestly say is that in some of the conversations we've had within the tags, that we are saying something that would be inclusive perhaps of both those components. You know, we know that there are some things that the state does really well, like the Medicaid product. We also know that we've got, you know, sort of our regional health systems that do a really good job, and they're moving towards equity as well. So trying to figure out how we don't just, you know, completely abolish everything, but that we use the learnings from all of the things we do well to try to create a really fully responsive product. So we've not made any decisions, but we're thinking about all of those things.
Thank you. Representative Wildy, we have a comment or a question, or a comment first. And so someone says, thank you for those numbers and those statistics. We appreciate it. And they also mentioned that there has been a large historic decline in the proportion of state revenue from corporations, which throws a greater burden onto citizens. Which method or methods of financing would help correct that increasing disparity from your perspective?
Well, the three I mentioned are a payroll tax. You mean a payroll tax can be employee or employer side, so it's all how you configure it. It presumably, the way most health benefits are currently structured, it's a shared responsibility with the majority being paid by the employer. But you of that 10% I mentioned, you know, 80-20 is a typical one, but not, I mean, you can set it up however you want. You could make it 10-0. The other ones would be the corporate income tax and the corporate activities tax. The corporate income tax doesn't bring a lot of money in to Oregon. There's lots of reasons for that, but the short version is we carved almost everything out of it, right? We gave them so many deductions that they don't have much income. So it doesn't raise, you know, I think it's 0.7 billion a year. It's not a lot of money at all. And so it'd be a very significant restructure to do it that way. And then you could do more on the corporate activities tax. That is a sort of a new approach. I think we're still trying to see where the problems arise, you know, because it advantages some business models and disadvantages others. Whereas if you do it in payroll, it frankly is the simplest. Businesses are already, you know, when I ran the Lane County Medical Society, if you'd said you can pay 10% on your payroll and not have to worry about healthcare, I would have been delighted. It would have been a huge savings for a small business. Larger businesses may get better deals, but it tends to be the most efficient and closest related. So that's my take on it. But those are the three ways you get more from the business side.
Yeah, thank you. So with those three different methods, are you leaning toward one or another, or is it just too early to tell?
Payroll tax makes the most sense, honestly.
Okay.
Don't get me wrong. I'd love to fix our problems with our corporate income tax, but there's the fundamental problem with that one is we are tied to the federal tax code in that, and so whatever they do, we have to affirmatively disconnect from. So every time we fix something, the federal government breaks something else, and then we have to come back and fix that. Whereas payroll tax, we would have control over and not have to worry about the federal government.
Representative Rayfield, would you agree with that?
Yeah, I think the one thing that I would add on to it is a paradigm shift, right? About how we're paying for it. And, you know, as you know, eventually, you know, a lot of big policies like this, eventually the folks that oppose this, right, the institutions that oppose this could send this to the ballot if this was passed legislatively. And so whatever type of mechanism you're looking at has to pass muster, and we have to think about what are Oregonians ultimately going to be comfortable with. I would agree with Representative Wildy that you know, moving it more towards the payroll taxes, I think, you know, makes a lot more sense than some of the other mechanisms. But ultimately, we do have to take that into consideration as well.
Okay, thank you, thank you. Let's see, we have a question. I'm going to read the question first, and let's see who wants to respond to it. Again, we have about 10 minutes. What changes may, well, this is a great question. What changes may or may not happen with the current silo between medical systems and the mental health / addictions and developmental disabilities within our senior service community? So in essence, when we talk about the sort of silos between the medical systems and the mental health and addictions, what type of mental health is included in this statewide healthcare plan?
Yeah, I guess I will start. So when we met to talk about provider reimbursement, again, there are two representatives that come from disability rights that also talk about mental health. And so some of that conversation is that, there perhaps isn't a eagerness to become a part of a system very different than the one that is working for some. So we could always do better. We could always have, better access, more providers, better networks, greater coverage. So those are things that are goals. But in terms of wanting to package it, in terms of full care through a central provider, does not appear, at least currently, to be something that many are interested in. And so we're responsive to the community whose needs we're trying to address, not the problem we're trying to solve, because it still won't give the kind of outcome and access if the people who are receiving the services, don't believe in it. So we're trying to better understand what that might look like. In terms of how nurses and other providers look at it, we need full, mental health services. Again, if you don't have that, then nothing about the physical health is going to matter. Right. If you're distressed or psychotic or depressed, then you're not going to take your medication for your blood pressure or your asthma medication or anything else. You're not going to remember to eat your food, and you're going to have deficiencies other places. So it's essential, if what the ultimate goal is optimal health, we've got to make sure that that's fully covered as well.
Mm-hmm. Thank you.
So Jason, if I could add to my colleague's statements, again, this is an opportunity for advocates for mental health and the services, either to protect the services or to expand the services, to get involved. The technical advisor group on eligibility, benefits, and affordability, we talk about this. There are behavioral health specialists and providers who are on the task force, and we frequently view things from that perspective. There is always room to expand the information and to expand to eliminate our blind spots. So again, a plug for those of you who are advocates for mental health, please get engaged in the process.
Thank you. Thank you. Let's see, here's another question here, maybe for our representatives, or maybe even Olivia, if you have a perspective on this. When would you expect a bill on universal health care to be on the ballot, to be voted on by all Oregonians? And maybe from Olivia, do you think this is something that we should vote on, and if it does make it to the ballot? So maybe with our representatives first, if and when do you expect the universal health care bill to be placed on the ballots? And then for Olivia, should we even place this bill on the ballot?
November 2022. Honestly, we already can't meet our deadlines, and we're going to have to get more time probably from the legislature because of everything that's happened with COVID and frankly, the fact that people have other jobs related to that. So we are expecting to extend our timeline. Also, the next election in which a significant number of people will vote would be November 2022 as well. So that would be my guess.
I'm going to have fun on this one, Jason, if you don't mind, and disagree with the good representative, because that makes these things more exciting. Because Adam is now corralled by my wife. So but they think what I like to think about in these situations, there's several things that we need before you're going to get acceptance by the folks. People have to have trust in the underlying healthcare system. So if I sit there and I go to my neighbor who's receiving healthcare through Regents or Providence or Kaiser, and I say, hey, by the way, you're now going to go through that Medicaid CCO. When they don't know or don't have the education behind that, certain folks are going to have resistance to that. All of those same arguments we've heard on a national level with the Affordable Care Act, and I think there's a lot of prep work that we can do that must be done if we're going to move in 2022. People have to have trust in government. I think it was one of those very first questions that on the poll is, can the government effectively do that? The paradigm shift, tons of questions in the chat about what does a payroll tax look like? How is that going to impact small businesses? The shift in the business mindset of saying, I'm no longer paying a premium. It's okay. I'm paying, and I'm paying roughly the same amount, but I'm paying it through a payroll tax. How do we structure it where it's a progressive tax and get people to understand that, where instead when you pass this at the ballot, right? Because if we pass it in the legislature and have 3/5, someone's going to refer it to the ballot. And when it comes to the ballot and the measure says this measure raises $100 billion or 20 billion, it doesn't matter, 20 billion, $10 billion in revenue, right? It doesn't matter that we are offsetting costs that are already being paid into the system. Politically, that's what's going to be said. And so if that's going to happen, we then have to have stakeholders who are willing, and I'm going to be real candid, stakeholders who are going to have to be willing to put millions and millions of dollars into a ballot initiative. If we remember, ballot measure 67 was almost $20 million that folks spent on that ballot measure, right? And so we have to build a coalition of folks that are going to support this at a ballot, grassroots, but also fundamentally, we have to pay for those ads and educate folks, and not just 30-second sound bites, but we have to fight against that institutional bias that is present in our society, where this is labeled as socialism and not about healthcare for our neighbor and healthcare for everyone. So I think it's possible we could do it in 22, right? I think that's a lot of work to get done, and I get nervous that we may not get there by then. So I apologize, Representative Wildy, but we got to have some drama in these things.
That's right. That's right. Keeping it real. Thank you so much. Olivia?
Yeah. I might have to disagree with both of our statements.
Oh, wow.
I'm kidding.
Yes.
I think that I think we got to look at if we could model something is from our African-American leader, Stacey Abrams, Georgia. So what does it mean to get something on the ballot? What does it mean for movement building in the state of Oregon to get our communities of color registered to vote so that they can exercise their constitutional right to vote for something that will ultimately benefit them? So that, I think, in terms of the coalition building, we got to work and expand our coalition to grassroots advocacy to ensure that we knock on every door of all of our communities of color that get registered to vote and that exercise their advocacy right for access to healthcare. And then beyond that, I think it's also in terms of implementation. How does this actually trickle down to communities and also to our white allies, white middle class in the state of Oregon? How can we politically move our community along aside us? The state of Georgia, I think, is a lesson for us to really look at what does democracy mean, what does moving this cultural shift means in our state, and how do we work across the aisle to really build a joint and very powerful coalition to ultimately get that passed. And so we've learned from other measures, progressive measures here in the state of Oregon. So I think it can happen, but it will take a lot of work. It will take a lot of resources, and it will take people to move out of their comfort zone to come alongside us.
Wow, thank you so much. And on that note, yes, snaps all around. And on that note, we are at time. Please join me in thanking our panelists for spending time with us and sort of sharing knowledge and awareness. Thank you all so much. I would also like to give a plug and a shout out to the Mid-Valley Healthcare Advocates and all of our partners, or all of the partners that made this first town hall event happen. And everyone, be safe, wear your mask, and until we meet again, everyone take good care and have a great evening and Happy New Year. Bye-bye.
Thank you, Jason. Good night,
Thank you
everybody.
all.
Thank you, Jason.
Thank you.
Good night.
Good night. Thank you.